the goal of this presentation is to explain what are the best indications for this technique. This surgery, almost unfamiliar, isn't so recent. Different percutaneous techniques exist. At the beginning, there was no fixation, but after, percutaneous fixation appeared, and minimally invasive surgery also. My goal is not to show you that the best way is with or without a fixation. A lot of studies showed that the results were similar. One of the most common techniques was born in the 70s in USA. It was practiced by a podiatrist, but as no theoretical or practical learning basis were available, the technique was rapidly abandoned. But Stefan Ischen, an American orthopedic surgeon, started publications and objective outcomes. He was already working with Mariano de Prado, a Spanish orthopedic surgeon, who, with Dr. Pau Golano, a very famous Spanish anatomist, imported the technique in Europe. This Spanish team organized various training courses in Spain, and I was lucky to complement my training there in 2006. In order to take the best decision to treat efficiently our patients, the best exam necessary is a good X-ray realized in complete weight bearing. The incidence of the X-ray is 20 degrees from the vertical and centered on the first cuneo-metatarsal joint. The good quality of this X-ray could be checked easily by clear visibility of the first cuneo-metatarsal joint, a rounded aspect of the metatarsal heads, and the proximity of the sesamoid to the metatarsophalangeal joint line. For this surgery, if percutaneous is basically performed under optimal conditions. Beaver and blades are thin and ensure a high level of precision when releasing of the capsule and ligaments or performing tenotomies. There are low incisions of 2 or 3 millimeters. The elevator is used to detach the soft tissues from the bone, creating a space in order to work safely. Burrs are essentials. Straight Shannon burr of variable thickness, and length for performing osteotomies, and wedge burr also of variable sizes for bone resection. The motor is a crucial element. It should have the same axis of rotation as the burr. Off-on switch and speed adjuster should be controlled by the foot pedal in order to control the hand piece with the best precision. It must have a strong couple to allow burr rotation during bony procedures at a very low speed, which can not exceed 8,000 revolutions per minute. The fluoroscopy used to guide the procedure. The goal is to obtain good images and deliver radiation dose 10 to 100 times lower than the conventional X-ray. Material is essential for this surgery. We used, as I told before, beaver and a blade. They are very thin to allow the incision about 2 or 3 millimeters. They need to be used with a very good precision in order to make a release of the capsule, tenotomy, or ligament release. We need also an elevator who is going to build a little space in order to work safely. We used some burrs, some Shannon burrs to make the cut of the bone, or a wedge burr in order to perform an osteoresection. The motor is essential. You need to have a very big couple in order to work in bony situation with a low speed rotation around 8,000 revolution per minute. We use a pedal to control the speed and the rotation of the motor in order to have the end completely free to perform the best surgical procedure with the best precision. Well, speaking about indication, what are the best indications? Of course, hallux valgus is one of the best indications. And to see if hallux valgus could be corrected by percutaneous surgery, as I told you before, we need to refer to the X-ray. And then we're going to see the X-ray. And if there is a metatarsus varus, we need to be very cautious, because the Hicham-Reverdin technique can't allow to restore M1, M2 angle lumbar. This technique only could short the angle about 3 degrees, which is not enough in a lot of cases. Then, if we have metatarsus varus, M1, M2 angle very open, we need to do or a double osteotomy, which is an inconvenience for the patients, or chevron osteotomy, percutaneous chevron osteotomy. It's possible, but then we take a risk in order of the stability of the cut. The MAA angle could be corrected easily by percutaneous surgery. Sesamoid belt, the level of this sesamoid belt need to be noted before the surgery, and it could be easily corrected by percutaneous surgery. The intraphalangeal angle valgus is already corrected by percutaneous surgery. And the length of the first metatarsal could effectively shortened by an percutaneous surgery, but we need to be very cautious before the surgery, because if we have a very short first metatarsal, this kind of surgery is going to shorten more of the first metatarsal, which could be very dangerous. The foot architecture is very important to be noted before the surgery, because if you have a square foot before surgery, it couldn't be different after surgery. A foot who cannot fit in a pump before surgery could not fit in a pump after surgery. It's impossible. And this is very important to explain to the patients, especially to young women, that we are not aesthetician surgeons. We are just making a surgery to treat them. Well, the first step of the treatment of the hallux valgus treatment by percutaneous surgery is the exostosectomy. We used a plantar incision about 2 or 3 millimeters, and we create the space to work with first the blade and after with the elevator. And then we used wedge burr, 3.1 millimeters, conical wedge burr. It's better to perform this procedure. And as you can see in the picture, I'm not using every time the fluoroscopy. I'm using my finger, my left finger, just to feel where is my burr and where is the bone to remove. We work without tourniquet. Why? Because the blood is necessary to reduce the temperature, to avoid bone burn, and because the blood is going to help us to remove the bone debris, as you can see in the second picture. The second step of this treatment is the Isham-Reverdin osteotomy. This Isham-Reverdin osteotomy is practiced by the same approach. The goal is to make a cut which is 45 degrees comparing with the axis of the first metatarsal. Why 45 degrees? In order to procure best stability of the cut. Then the cut is performing by the same incision. We start the gesture in the medial part of the metatarsal, and then we go to the dorsal part, and then the medial part, the lateral part, sorry. The cut need to preserve a little part of the lateral cortex intact, and after we finish the cut in plantar side, using simply the first two to make a little varus, we can close the cut, as you see here. The cut is open. Do you see my my mouth moving?
Yes, you can see it. Thank you, Dr. Bruno. Yes.
Here the cut is open, and just applying a varus with the first two, we can close the cut. The third step of this surgery is to perform the lateral release. We introduce the blade in the joint parallel to the tendon, and then we go in the plantar position. Then after the blade is turned around 90 degrees to the lateral part, and then making a varus with the two, we release the tendon, the adductor tendon in the plantar position, and at the beginning, we always use the fluoroscopy just to see if the release is enough. After having our learning curve, we use less fluoroscopy, and just with the feeling, with the sensation we have pushing the two, we stop the chest. It is very important to stay in a plantar position, because if we go more proximally, we can cut the lateral ligament, which is very dangerous and could allow metatarsus varus, an hallux varus. Last step is the Hakim osteotomy. Hakim osteotomy is an osteotomy of the first phalanx. Proceed as the same procedure for the metatarsal cut, but the difference is that this cut is vertical and non-oblique. This cut is performing by medial approach. We make first the cutting of the medial part of the cortical, and then the plantar part of the cortical. Then we let a little part of the lateral part intact, and we finish with the dorsal part of the first phalanx. Using also a movement, a varus movement of the first two, we close the cut as here. Other indication of for the percutaneous surgery, this is the hallux levitus or hallux rigidus. This is arthrosis of the first metatarsophalangeal joint. Simply, this is very famous in marathon athletes. This is also very frequent in young soccer players, and it could be sometimes confused as an osteochondritis. But it's the first, this is a an arthrosis of the first joint due or for an excess of pressure on the first two, or due to microtraumatism, as it's frequent in young soccer players. The treatment starts with the exostosectomy, as for the hallux valgus treatment. It could be stopped at this stage sometimes. Sometimes we need to make a Waterman osteotomy, which is an osteotomy who take off the exostosis and close the angle of the first metatarsal head. As in this row, you can see how to perform this osteotomy. The risk of this osteotomy is that the cut is very vertical, and then if we don't preserve plantar cortex, we could have a displacement of the cut secondarily. The whale osteotomy of the first metatarsal is very easy to perform by percutaneous surgery. The goal is to first remove the exostos, the osteophytes, and after to make a cut, oblique cut of the head of the first metatarsal, as we do for the Hicham-Reverdin cut, but there is no preserving of the cortex, and then the goal to this osteotomy is to put the head backward and forward, as you can see in the drawing. Well, lateral metatarsal pathologies could be treated also by percutaneous surgery. We can use an arthrolysis of the metatarsophalangeal joint to avoid stiffness and phalanx deviation. We can also perform a section of the transversal metatarsal ligament, which is indicated for percutaneous treatment of Morton neurona. Personally, I prefer remove the Morton neurona when it's shown in the RMI that there is a Morton neurona. But some authors propose to just cut the metatarsal ligament, the transverse metatarsal ligament between the second and the third metatarsal generally. MTP osteophyte resection for post-traumatic lesions, or simply for arthrosis of the lateral metatarsal tooth, could be performed by percutaneous surgery. And very frequent gesture we made by percutaneous surgery is the DMMO, which is simply a whale osteotomy performed by percutaneous surgery. It could interest the second, the third, and the fourth, and sometimes the fifth metatarsal. You can see here very frequent image of what we obtain after percutaneous surgery of the metatarsals, of the lateral metatarsals. Sometimes it could be, you could be afraid to see this kind of X-ray, but the reality is here. The patients are very, very, very happy with this surgery. They have no pains after surgery and very good results after this kind of surgery. And as you can see in this picture, I mixed open surgery with scarf osteotomy and percutaneous surgery for this patient. Tooth deformity could also be treated by this kind of surgery. This is a la carte menu, as we told in France, because we can do our tenotomy or osteotomy by this kind of surgery, and it's sometimes difficult to explain you what we can do for each tooth, because sometimes we just need to make a release of a lateral ligament. Sometimes we just need to make a cut of one phalanx or two phalanx sometimes. Okay. Canthus varus disease are also well treated by percutaneous technique. We should to perform at the first step simply bone resection of the lateral part of the lateral condyle, and after an osteotomy of the metaphysis in order to reduce the angle between M4 and M5. Well, this is a very good technique, but there is some risks possible. An inadequate bone resection could goes to an instability of the joint if you remove too much bone in the, for example, in hallux valgus treatment, you remove too much bone in the medial condyle, you can have an instability of the metatarsophalangeal joint, which is more frequent in patients with osteoporosis. Too low resection lead to the same symptoms as the patient has before surgery, and then it is not a good solution. The hallux varus after percutaneous surgery is not so frequent. It could be allowed simply by respecting the lateral ligament of the metatarsophalangeal joint when we make the release of the lateral part. Metatarsalgias of the medial metatarsus is described in some literature, but in reality, we make a lot of time a surgery from the first hallux, from the hallux valgus to the second, the third, or the fourth two at the same times. Lesion of vessels and nerves could be avoided also with a good understanding of the anatomy and a good learning curve. Loss of correction, yes, it could be observed, but the literature shows that if the good indication is taken, loss of correction are not so frequent. Well, the post-operative management is very important. 10 days after surgery, the first clinic has the goal to remove the wires and perform this kind of orthoplasty with silicone paste, and then we perform these dresses, and the patient can leave the clinic working with this kind of shoes, and we see him again for the second clinic at the 1 month after surgery. 1 month after surgery, an X-ray is made just to perform to see if the cuts are now closed, and we ask to the patient to start this proper rehabilitation, as you see in the picture, and we ask him also to make a little strapping of the third and second two. He's going to make this strapping every morning and remove it every night himself during 1 month. And then we will see the patient for the third consultation at 90 days after surgery. A new X-ray is performed just to confirm that the hearing bone, and we continue the rehabilitation of the patient with these results. What are the take-home message now? Now, as you can see, and I insist a lot on that, a good X-ray analysis is very, very, very important to know if we can or if we cannot treat the patient with a percutaneous surgery. We need to don't forget the past. Don't forget these good techniques as calf surgery, chevron surgery, or lapidus technique, who shown that they have very, very good results in the past. The learning curve is very important. At the beginning, when I learned this technique, during 1 year, I never can do the technique because I was very afraid to what I'm going to do. But in reality, with good indications, you see that the patient is really the good patient to be treated by percutaneous surgery. If there is only a DMAA deformity, he is the best patient. And then the learning curve is very important, and we have the change in Aspetar to have a lab, and young surgeons and students could perhaps in the near future learn the technique in the lab. Then you are going to say, but is it possible to correct big deformities? Yes, it's possible. You see this hallux valgus, very important hallux valgus, and in reality, with a good analysis of the X-ray, this is just a very big DMAA deformity, and we operate the patient with these results. And you are saying it is possible with athletes. Of course, it is possible with athletes, but we just need to have this X-ray interpretation very close to the patient and have a good rehabilitation after, and it is possible for the patient, for athletes patients. Thank you for your attention, and sorry to make this speech in this condition. I'm going to try to have the image of everyone. Okay, Paul, if you want to start the discussion.
Yes, thank you very much, Dr. Bruno. Excellent talk and very clear, and your slides were all brilliant, so we could see them after that small glitch. So we have a question here. Good morning, doctor. Since I'm working with Paralympic athletes and many athletes with cerebral palsy with spastic foot muscles have combined foot deformities like pronation, hallux valgus, etc., are your foot surgery techniques, could they help them for good functional outcomes? So that's the question in Paralympic athletes with cerebral palsy.
Mm-hmm. Okay, I don't have the experience with Paralympic athletes, but I have the experience with patients with troubles secondaries to Volkmann syndromes in the foot, which is much more the same problem with some tendons retraction, etc. And yes, we have very good results with this technique. I'm speaking only about the foot, of course, and the position of the tooth. And yes, we have very good results with this kind of techniques, yes.
Second question, can we fix extensor hallux longus subluxation?
You know, when there is a very big deformity, the first thing we have to do is to make an X-ray. And if the X-ray said there is an opening of the angle between M1 and M2, I think this is not a good technique to apply to the patient.
Dr. Rashid is asking, what about Quintus varus? Do you deal with that?
Yes, of course. As I spoke about that in my speech, you see that there was just 2 slides about Quintus varus, and the results are very good. And every study has shown that there is no difference between percutaneous surgery and open surgery in the treatment of percutaneous Quintus varus. But the advantage of the technique is that the patient return to activity very quick. He can walk the day after the surgery with special shoes, as you show, as I show you. But it's a very good technique for this kind of deformities. Yes, of course.
And a follow-up question from Dr. Rashid. What is the angle of the hallux valgus to decide surgical correction?
Well, this is not really the angle of hallux valgus, because hallux valgus angle is the measurement of the angle between M1 and P1. But the very interesting angle to see is the intermetatarsal angle between M1 and M2. If you have an angle which is more than 16 degrees, I think the best thing is to make an open surgery. But you need to see different things. For example, if the patient have a large foot, which is common sometimes, perhaps you can perform the surgery. The important thing, I say to the patients, if you have a very big opening of the M1 and M2 angle, we can perform a percutaneous surgery. But the result is going to be as a duck foot, which is not very good results, I think.
We have two questions from your colleague, so I'm going to ask Dr. Johnny Anderson. You can take the microphone and unmute and ask your question, Johnny Anderson, and then after Johnny, Peter de Woog. Johnny, do you want to ask your question?
Yes, do you hear me?
Yes, we can hear you.
Yes.
Okay, thank you. Thank you, Bruno. Very nice lecture. I have just two questions. Is it possible to perform the Jangswick osteotomy percutaneous? And do you have any figures of the frequency of sensory nerve injuries for this percutaneous procedures?
Yes, good question, Johnny. The different approach are made especially to avoid a lesion. The medial nerve is the medial and dorsal nerve is the nerve the more which have the most exposure in this kind of surgery. And this why? Because we made a plantar incision in order to avoid any lesion of the nerves. And it's very important to begin with the blade, make an incision and go directly through the skin to the bone, and then start to detach the different tissue from the bone with the blade, and after take the elevator just to increase this working room, in order to preserve every nobles, nerve and vessels to avoid any injury.
Thank you, Bruno. And what about the Jangswick osteotomy? Is that possible?
I never perform it. I cannot say if it's possible or not. I never do that. Sure, I prefer to stay in a very stable osteotomies,
Okay, it was just a question from a hand surgeon. Thank you, Bruno.
Peter de Woog.
Thanks a lot, Bruno. It was very interesting. Now, the Aspetar has, of course, a reputation in niche sports. And we know that this is a disease or a condition that affects females a lot due to wearing shoes, but also it can be genetically quite triggered from the male part. And especially in the male, it can be quite painful and extensive, although it's more rare. So in summary, if you have an athlete who has this and you decide to operate on that athlete with realistic expectations, what do you say about return to play time in a regular case?
I think we need to be very cautious because, as you see, there is no fixation. The patient is allowed to work immediately after surgery, and the dress is very important. If the dress is maintained during 1 month after surgery, and the X-ray after 1 month after surgery is made and show that it's okay. It is not for let the patient return to sport. I think no sports before 3 months after surgery, according with the X-ray. Are you okay with that, Peter?
Thank you very much, Bruno. I enjoyed it very much. Thank you.
Thank you, Peter. Dr. Rashid has two questions, both on Morton's neuroma. So what do you think about corticosteroid injection for Morton's disease? And the second question is symptoms in ballet dancers developing the same in ballet dancers than in athletes for a neuroma between second and third toe.
Okay. Concerning the Morton neurona, injection are the first step of the treatment. The surgery treatment is the last treatment possible for the patient. We know that the neurona is due a lot of time to a conflict between the second and the third metatarsal. One of the etiology possible of this Morton neurona is that the two first metatarsal are made to the propulsion of the walk, and the third, fourth, and fifth metatarsal are made to change the direction. And then between the second and the third metatarsal, there is a conflict, and the nerve in the middle of these two metatarsals is going to be, I would say it, stimulated. And then the first part of this disease is an inflammation, and of course, an injection could be reduce the meaning of the patient. As I told, the removing of the neurona, of the Morton neurona, is the last step of the treatment. And sorry, could you repeat your second question?
So the second question was, do we see the same symptoms in ballet dancers developing neuromas between second and third toe than in athletes, I suppose?
Yes, it's possible, but we need to have a very good analysis of the symptoms of the patient. We can see that effectively in this kind of population, but we need to have a very good analysis of the appearing of the treatment and the symptomatology in general before to say yes, it's possible or not possible. Okay.
Thank you very much. So if there's no further questions, I want to thank Dr. Bruno for presenting the first online tutor lecture ever. It was great to have you here with us, Dr. Bruno, and welcome again to Aspetar. You had more than 190 licensed healthcare practitioners listening to you this morning, so wonderful. Thank you everybody for joining us this morning. Next Tuesday, we will do the same time, 8 o'clock. And of course, there are a number of other online education activities during the week, this week, next week, and also the rest of the month. You can visit the Aspetar website to see more about that, and also your department coordinators. Thank you again, Dr. Bruno. Everybody, have a nice day. See you next week.
Thank you very much. See you.